Thank you very much, Saurabh, for the very kind introduction and for having me a part of this. I guess this instruction course is about yellow spots. So, thing is, when you see a yellow spot, which doesn't look like what Anand was showing you, like it looks like an inflammation to you, ask yourself a couple of questions. And those questions are, is it chorioretinitis or is it retinochoroiditis? If you think it is mainly choroiditis, is it focal or diffuse? Go back to the slit lamp and see if there are any signs of inflammation in the vitreous or anterior chamber. They may not be on your face, but go back and look for it. Then comes the question on imaging, is it involving the choriocapillaries or the stroma of the choroid? Is it just an ocular disease or is it a part of a systemic disease? And what are the imaging findings and how is it responding to therapy? Now, I show you example of this yellow spot in the fundus. You know, we all understand it looks like inflammation. So let's answer very simple questions. What is it? It is retinochoroiditis because you see the retina is involved, the edges are not clear, and you have something called headlight in fog. It appears yellowish. It is definitely focused. There is overlying vitritis. There is no associated systemic disease. And when I said look at the healing pattern, now if you look at this is the scar created out of the previous episode. So what you have is one scar, another scar, and now the active lesion, which means satellite lesion. So headlight in the fog, satellite lesion, focal retinitis. What is the diagnosis? It is toxoplasmosis. Do you need any investigation? No. Serology absolutely has no role to play in any of the uveitis except HIV and maybe syphilis. You don't do serology to tell you the patient has toxo, nothing. Just start the treatment. Fluorescein required? Not really. If you really want, well, this is what it is going to show you, hypo surrounded by a ring hyperfluorescence. But to be very honest with you, I will not do fluorescein for this patient. Just start him on treatment, antitoxo and steroids, and this is how the patient is going to respond to your therapy. Do you honestly need the angiograph to show it? No. It's just the fundus or your clinical exam is enough. Now we have another case of yellow spots. This is a 9-year-old child, actually a child of a retina person, a retina specialist. Now she says there is floaters since last 1 week. She was diagnosed as multifocal choroiditis in the left eye and was started on prednisolone. And this is how the left eye looks like, yellowish spots, multiple. Again, ask similar question. Now, this one is predominantly chorioretinitis. The retina is not much involved. And this answer actually comes from OCT if you're not sure clinically. It is multifocal. There is no associated inflammation. Now, what does it involve? Stroma or choriocapillaries? And that is the answer I'm going to get on imaging. Is there a systemic disease? She is carrying the report that she is Montius positive, but other than that, we do not have, and it's a child. And we still do not have any healing pattern available because it's a first episode. So let's do the OCT. Now, this is the OCT, which shows that what you essentially have is the involvement of the outer retina and something here happening at the level of the choriocapillaries. So whatever the action is, mostly it is at the level of choriocapillaries and outer retina. So this is the non-invasive one, which is OCT angio, and this is the segmentation slab taken through the choriocapillaries layer, and you see multiple dark areas of flow void on choriocapillaries, which means it is a disease, yellow spot involving the choriocapillaries with outer retinal involvement, which is secondary to it. So that becomes primarily choroiditis. Now, very interestingly, when both the parents are doctors, it's a problem for the child because they apply a lot of their mind. So what we have is choroiditis, multifocal, posterior pole, bilateral. Right eye was minimal, left eye more. No inflammation, primarily involving choriocapillaries. So what would you suspect? TB or sarcoid, because these are the two diseases which would behave like this. Her montus, I told you she was carrying with her, was more than 15 mm. She had a CT scan of the chest which shows subcentimetric lymph nodes. Quantiferon was negative and ESR they were carrying. I don't get ESR done from my patients, but it was 10 millimeter, whatever it means. However, they had also investigated her for all the possible rheumatologic disorders, and they said ANA is positive, which is diffuse homogeneous. Double-stranded DNA is positive, which is diffuse homogeneous. And there was a rheumat consultation with them, which showed there was no evidence of systemic TB. Now you ask yourself a question. Does it look like lupus to you? No, because it is primarily the involvement of the choroid. The retina is not really involved. So how about this ANA positivity which there is? So of course we repeated the autoimmune titers from here. ANA was borderline positive. Double-stranded DNA was 42, which I'm told should be below than 40. And whatever by another technique, clef was faintly positive, complement was normal, immunoblast analysis showed anti-Rho positivity, Lyme was negative. So the treatment was, because then my rheumatologist told me that if you have latent TB, it's very common for ANA to become positive because there is some shared pathways between this. I will not go into that. But the thing is, the context has to be what you are looking at. And this is following treatment with anti-TB drugs and with steroids, of course. We now have a 5-year follow-up for her. You can see in left eye, most of it has been restored. And she hasn't recurred since last 6 years because we have added ATT to it. Had you missed it and treated her only with steroids, it would have responded very well. That's not a doubt. But the disease would keep on coming back again and again if you do not address the specific cause. So as you can see, and this is what I wanted to show you, that the choriocapillary voids which we see is reversible up to a certain point, and when they are very small and you intervene aggressively with your steroids and whatever it needs, they reverse. You have a reversibility. When they are more than 0.1 millimeters square and you delay your treatment, they try to become diffuse and then they present like diffuse form of serpiginous choroiditis where the vision would be compromised. So you don't want to reach there. You want to intervene at a point where it is reversible. Do I have time? I thought it was over. No? Almost there. And the last one here is, these are the yellow spots, again multiple one, but when you do your ICG, you see the diffuse thickening of the choroid even without doing ICG. This is very classically VKH. You don't need any investigations. It is choroiditis, multifocal, serous detachments, vitritis, stromal. You intervene and you have a complete reversibility. So I will skip this one. The concluded, you got to keep it simple. Don't complicate your life reading the so many etiologies. And I think with ChatGPT, you don't have to learn all the causes of everything, but you still have to learn the art of applying that knowledge to your patient. That becomes a very important art. And I see a lot of youngsters. Please do not try to mug up from the textbook this as a cause. Just try to see, understand, and then apply it to your patient. Thank you, Saurabh, once again.